Hello, my name is Anthony Hayes. This is MSN 627. We'll be talking about radial artery sheath removals. The purpose of this procedure is to outline the process of safe removal of the transradial sheath from patients following cardiac catheterizations. This includes minimizing patient discomfort, complications related to post-sheath removal. Cardiac catheterizations can be performed via transradial or femoral approach. Both methods can cause complications following sheath removal. Using the radial artery has lower bleeding risk and lower vascular complications than a femoral approach. Nurses are trained to remove the sheaths themselves prior to the patient coming to the floor. They are observed by 2 or 3 different nurses removing 2 or 3 different sheaths, then they get checked off, and then they're able to remove them on their own. Of course, with any time of a puncture or any kind of sheath, there's always risk of complications. Some of the patient-related factors that can cause complications, of course, would be female, elderly, just because they have natural coagulopathies, kidney disease, hypertension, high BMI, peripheral artery disease, and acute MI itself. There are technique-related factors: the size of the sheath, ineffective manual compression techniques, multiple puncture sites. Pharmacotherapy factors can include over anticoagulation with heparin during the procedure, and anticoagulants, antiplatelets that the patient may take at home following MI or having some sort of surgery itself. So when the patient comes to the floor after the heart cath, they'll have 99% of the time what's called a TR band. The TR band itself is covering the site where the radial artery sheath was. So some equipment that you may need at bedside would be your monitor. You want to be able to check the blood pressure, heart rate, and assess the radial pulse. So you would do neurovascular checks every 15 minutes for an hour, 30 minutes times 2, and then every hour for 4 hours. I don't have the luxury of having a TR band, but it basically looks like a big water ring that goes around your wrist, like you had when you were a kid. Has a little port on it, and it comes with its own syringe that you can actually withdraw the air from the band itself. As far as removal of the TR band itself, it's all hospital specific as far as time. You want to take into consideration the factors that went into the procedure, why the patient had the procedure, how much heparin was giving, natural coagulopathies, what was their ACT or ATC before the removal of the sheath. Most recommend 1 ml every 3 minutes. Some hospitals will go 5 mLs every 30 minutes until the sheath is removed, or until the TR band is removed. It holds a total of 10 ml of air. So once you get the air removed from the band, you can actually slip it just right off the wrist. You want to perform neurovascular checks on both arms and hands in order to establish a baseline. You want to verify the amount of air that was used to inflate the TR band and the time of the inflation. That's key, so you know how long the TR band has been on there. Most physicians don't want the TR band on the patient for more than an hour itself. You want to commence deflation of the TR band 30 minutes after the inflation time. This is done according to the doctor's orders. Like I said, it all depends on the hospital's policy and procedure itself of how much air you remove and how fast you remove it. You want the patients to be relaxed, laying in bed, just kind of hanging out with you until the band is removed itself. You don't want to increase any chances of bleeding. After a complete deflation, you remove the TR band, clean around the injury site with some antiseptic alcohol swabs. Place a small square of sterile gauze over the injury site and wrap it with Co-band, or you can use just some 2x2s and wrap it with tape. You want to create a slight pressure dressing. That way that they don't bleed freely or have a possibility of hematoma. You want to advise the patient not to perform any strenuous activities with that affected arm for at least 48 hours. You don't want them going home and lifting a refrigerator or mowing the yard, anything like that. You also want to advise them to watch for any cases of swelling, pallor, decreased capillary refill, hematoma, pain, bruising, any movement or sensation decrease. You want to have that checked out as soon as possible. Acute symptomatic RAO is extremely rare, but the presence of the hand or finger pain, weakness, discolorization, reduced temperature, or sensory deficits should be promptly and immediately investigated. You don't want this patient to lose any nerve or have any nerve damage or possibility of losing a limb just because they had a heart cath. There may also be oozing from the site. This may be coming from the tissue tract. Apply light manual pressure of the site for 5 minutes. Once hemostasis is obtained, apply a Band-Aid or a 4x4 with some silk tape. Continue to monitor. Of course, you always want to monitor for hematomas, signs and symptoms of infection, pseudoaneurysms, all that can be complications of a radial arterial sheath. Some are picked up with ultrasound. Some you can just naturally see the aneurysm itself. Education is key with these patients. You always want to, anytime you have a hole put in your body, you always want to educate somebody on signs and symptoms of infection, signs and symptoms of bleeding that can be a complication as far as a hematoma. So education is always key when these patients have these procedures.